I appreciate everyone to engage actively in our discussion. Once again, thank you for being here. Let's get started. And I would like to share my screen. Okay, does it work?
Yes, that looks great. Thank you, Linda.
Okay. Now, as what Melanie has mentioned, I would like to focus on the rehabilitation, a contemporary approach to support the continuum of care from aging in place to dying in place. And I have shown my email address here. After the presentation, I'd love to have further connection with all of you. If you would like to have further discussion, please feel free to contact me through my email address. Actually, to support the older adults from aging in place to dying in place, I would like to focus my presentation into three parts. Who are involved? Why is it so important? And how to achieve. First of all, who are important? Who are involved? The older adults are in fact a group of people with particular characteristics. They go through different stages in their later life, from independency to assisted living to end of life. Some of them, especially at the youngest age, are quite healthy. They are quite independent. They can have an active lifestyle and even carry out the housework as well. But as times go by, they become older, become weaker. They may need a certain kind of assistance to help them to stay in the home. When they approach the end of their life, they may face another problems and need additional help. They require various types of healthcare to support them and address their evolving needs. Without those supports, however, they are unable to age and die in their homes or community as they wish. I try to examine the definition for aging in place and dying in place. And for the definition of aging in place, the most representative definition come from WHO 2 decades ago. It means meeting the desire and ability of people through the provision of appropriate services and assistance to remain living relatively independently in the community in his or her current home or an appropriate level of housing. As you can see, I have highlighted desire and ability. This definition highlights the desire of the people to live in their own place and the ability to live in their place, which is quite a comprehensive definition. But on the other hand, when I review the definition for dying in place, it comes more recently. And from the literature, one of the definitions mentioned dying as the usual residence of the patient, including the home or a long-term care facilities. I come from Hong Kong, and I also make reference to the definition from Hong Kong, which state that dying in place is spending the final days as the place of choice of the patient, be it at home, in residential care home for elderly or nursing home, and not necessarily a hospital. Now, in these two definitions, the main focus is the venue only. They didn't mention anything about the ability. Therefore, I think that the definition for a dying in place still have some potential for further development because one should have the ability in order to stay in their own place. Then I examined the policy, the aged care policy in the countries. In fact, aging in place is a key part of aged care policy in many regions and countries. For example, in the UK, in US, Canada, Australia, New Zealand, Japan, Hong Kong, we adopt aging in place as our aged care policy, while at the same time, the policy also underpins services that support the old people to age in place. But however, dying in place seems to be a hidden discord in the aged care policy, in the literature, and in practice. And I believe that dying in place should be attached to the policy of aging in place. because they are two things. It seems to be different concepts, but actually they are related. And therefore, I advocate for expanding the concept of aging in place to include dying in place. Why is it so important? By linking up or expanding the concept from aging in place to dying in place, the reason is because the two concepts actually build on the same foundational principle. They are to enable the older people to remain in the preferred and familiar environment during their later life, and it also preserves the core essence of aging in place. To maintain the ability of old adults in their later life, that means to maintain their ability to age and die in place. And it also supports the older adults to maintain natural progression rather than a drastic change from aging to dying. By doing so, they can have more control over their daily living and own life matters. They can maintain a social connection and receive continuous support from the connections, and to be surrounded by the loved one during their final movement. In order to support the old people to age and die in place, a continuity of care is needed. It is required to ensure consistency and the quality of care throughout the entire care journey, and also address the evolving care needs of the older adults. When we talk about the continuity of care, I start to mention about the goals of aging in place and dying in place. For aging in place, our goal is to enable the older adults to adopt functional challenges that come with aging, to integrate or reintegrate into the community. We know that during the aging process, the older adults are facing decline in their health condition, but there may be up and down situations. Say, for example, if an older adult have sustained a fractured hip, uh, he or she may need to stay in the hospital for a while, receive the surgery and post-operative care, and then after the rehabilitation, he or she can go back to the home and reintegrate into a community, and that's the meaning of reintegration. And it also enables the old adults to maintain independence and active living in their home or community to live comfortably. For dying in place, the goal is to enable old adults to accommodate decline in health in the final days, still connect with their loved one, to engage in desired activity as far as possible, even though they are in the end of their life. Some of them would still like to perform some sort of personal care, such as washing their face, something like that. We would like to engage them to perform this activity as far as possible, rather than performing this activity for them, and enable them to fulfill their final wishes and die comfortably. When we've mentioned the continuity of care, in fact, there are three levels. They are the micro level, meso level, and macro level. The micro level refers to the relationship between people. It is the interpersonal attachments to a regular source of care. The older adults can receive continuous care from a stable, multidisciplinary healthcare team. The most important thing is that they know who to contact and where to go when they have unmet needs. As the meso level, that is the management continuity, it refers to the consistent approach to managing health conditions. It involves individuals within the healthcare team to have shared joint responsibility for consistent care and uniform solution. It requires to maintain a stable, well-defined organizational structures and professional role for multidisciplinary healthcare team. Regarding the macro level, that is informational continuity, it refers to the sharing of the older adults' medical records or information across the healthcare providers, across organizational boundaries, and across the episode of care. By doing so, the continuity of care can be achieved. Then, Okay, I mentioned a lot about the aging in place, dying in place, and continuity of care. Then, what are the strategies to achieve it? I propose to use rehabilitation. I visit the definition of the WHO about rehabilitation. It has mentioned that rehabilitation is a set of proactive and goal-oriented interventions aims to optimize functioning and reduce disability in individuals with health conditions in interaction with their environment, involve multidisciplinary healthcare skills, brings about the highest possible level of independency and quality of care. And I purposely underline optimized functioning and reduce disability. It encouraged or enabled the older adults to have the ability for what? To interact with their environment. Since they are staying in the home, staying in the place, and they need to interact with their living place and to age and die. Therefore, I love these two concepts very much. And when we talk about rehabilitation, many people automatically thinking of recovery. They may ask, can or can rehabilitation help of can we does we rehabilitation related to end of life care? They may have this kind of query. But in fact, rehabilitation can have different goals. One of the goals is restorative goals. It means to regain lost skill and function, which is also the well acknowledged recovery function of rehabilitation. The other goals include the preventive goals, that is to prevent deterioration in functions and prevent the occurrence of complications. And supportive goals means to maximize the functioning and participation in meaningful activities alongside disability. When disability happens, but we still want the older adults to have maximized functioning and continue to participate in meaningful activity as they wish. And finally, is the palliative goal, that is to adapt to irreversible change or losses in function or to adapt to the new reality. Now, these four goals may not happen at the same time. It depends on the situation and also depends on the health condition of the older adults. During the aging in place time, it might be the restorative goal and preventive goals are more relevant. During the dying in place period, the supportive goals and palliative goal may be more relevant, and it depends on the condition and the health. It depends on the health condition of the older adults as well as the need of the older adults. Okay, with all the backgrounds that I mentioned, together with my research experience in aging in place and dying in place, I am proposing a model to help the implementation of a rehabilitation care to older adults and help them to go through the journey from aging in place to dying in place. And this is the first time that I present my model, and I really appreciate your advice and comment on it. And this model starts from a multidisciplinary rehabilitation team, and they provide restorative, preventive, supportive, and palliative care. And this kind of care is characterized by a number of characteristics and can be represented by an acronym of PLACE, P-L-A-C-E. P represents personal, personalized interventions. It means tailoring the care plans to address the unique preferences and wishes of older adults to develop internal strength by providing external rehabilitation supports to them. Local support means integrating community resources and networks to create a supportive, conducive environment for aging and dying. Since the older people prefer to stay, age, and die in the community, therefore it is a good opportunity to integrate community resources in the care delivery. A represents holistic approach addressing the physical, psychological, social, and spiritual needs for overall well-being throughout the aging and dying journey. C represents the contextual care. It means embracing the concept of place as the care setting. All the The care will be delivered in the place, tailoring all the interventions in accordance with the specific living environment of the older adult. And lastly, E, it means encouraging participation from family, friends, and community to create a supportive environment. Altogether, we hope that this form of rehabilitation can help and support the old people to age and die in place. And I named this model as place-based model of rehabilitation. And then I try to make a comparison between my place-based model of rehabilitation with the traditional facility-based model of rehabilitation. In the place-based model, the care is delivered in the home or community settings. It can integrate the support from the local resources. The care tends to be more personalized, tailored to the individual needs and living environment of the older adults. Since older adults can live in their familiar environments, it can promote their mobility and promote independence as well. And the involvement of the family members and social individuals will be encouraged because everything takes place in the community. For transition to the end of life care, the place-based model will facilitate a smoother transition from aging to end of life care at home. One may assume that one may query that, okay, we are proposing a multidisciplinary care. Will it be very expensive? But I have another point of view because we are not, or we are reducing the use of the facility, reducing the use of the acute care services. It might be cost effective as well. When we examine the traditional facility-based model of rehabilitation, the care takes place in hospital or rehabilitation facilities, and it mostly relied on the service and staff within the facility. The care tends to follow standardized protocol, may not be able to fully facilitate mobilization because of the structured environment and the less flexible routines. And at the same time, it may lead to dependency on the staff, even for daily activity. And family involvement and social involvement may be limited. And for the transition to end of life care, it may be complicated because due to the varying institutional policy. And as a result of using the hospital services and institutions care, higher costs may be result. And you may ask, okay, I'm proposing the place-based model. And do we face any challenge? Yes, of course. I try to examine the opportunity and the challenge at the same time, and so that you can examine the issue in a more comprehensive way. For population characteristics, many countries are facing aging population. There are so many old people, and the demand is so big. But at the same time, because of the life expectancy of the old people are getting longer and longer, their health status are becoming more complex and they have changing health needs as well, and which is challenging to the healthcare providers. And the second one is about the care setting. We are proposing to deliver the care in the place, in the home, and which in fact is the desire of many old people. And I have recently completed my study in Hong Kong, which asked people what is your place, a desirable, what is the desired place for dying? And over half of them indicate that they wish to die at the home. That means proposing a team place-based about a model simply can match with the desire of many older people. However, the place is not a usual healthcare setting, and the place of the older people varies greatly as well. It is very challenging to the healthcare provider. They have to be very flexible in terms of care delivery. And then regarding the rehabilitation goal, as I mentioned before, the rehabilitation goal consists of wide spectrum of 4 goals, and they can altogether address the complex and changing health needs of the older adults. However, public people, the general public, usually remember about the recovery functions of the rehabilitation. They may have confusion about the well-acknowledged restorative function of rehabilitation and the palliative focus of dying in place. They may query whether rehabilitation can work in end-of-life care. We need a lot of health education and promote this kind of model to our public people. About resources, the availability of community resources such as charity, volunteers may contribute in the place-based model of rehabilitation. But we are also facing the challenge that allocation of resources often prioritize over restorative functions over palliative functions. Say, for example, the donor, if they wish to donate the money for some service that supports the people, they would like to support those people who have a future. And this is quite normal. And therefore, we are trying. It is a bit hard to get funding or get resources to support end-of-life care or palliative care. Regarding the technological and geographical issue, advancement in technology does help a lot in place-based model of rehabilitation. The remote telehealth, remote monitoring do helps a lot in providing care to the old adults who are living at home. But there are also some old adults who are living quite far away from the city, from the hospital, or from the healthcare services. Therefore, accessibility is also a barrier to some of the cases. And I would also like to highlight that no single discipline can provide all the care needs for older adults to age and die in place. That's why I propose a multidisciplinary approach. This multidisciplinary team may contain a lot of healthcare professional people inside. The doctor manage the medical condition, control the symptoms, the nurse promote comfort, monitor the health condition, the physiotherapy, design exercise, strengthen the muscle, improve the balance and mobility. The occupational therapies may help in introducing assistive tools or home modification when the older adults needs to have some sort of assistance in their living. The social worker may integrate community resources and protect the rights of the older adults. The speech therapy can address the swallowing problem and communication problems. And the health volunteers, even though they are not healthcare professionals, but they can perform the role as ordinary people helping ordinary people. They are living in the community. They are important resources to provide support to their nearby neighbors. And if they are adult as well, older adult as well, they are experiencing the aging process. They can share the information and even tips in living in the community. Therefore, a multidisciplinary approach is desired. And moreover, the multidisciplinary approach usually adopt a more holistic view in assessment, delivery of care, and evaluation. Therefore, a more comprehensive care plans can be developed. Then, I mentioned something about research evidence. You may think of why I mentioned the research evidence, because I mentioned to you, I developed the model, but I still need to conduct a lot of research to test the model. Say, for example, I need to define the concept of place. What are the outcome indicators for the place-based model? How can the care be delivered? And what are the short-term and long-term outcome for this team-based model of rehabilitation? I know that in order to address different research questions, we need different types of research methodology, but I still want to present some of the generic research methodological considerations for discussion. Regarding the research design, I suggest to adopt the pragmatic research design to look for the effectiveness of the model in real-life situation. It involves the stakeholders, the older adults, the caregivers, the publics. Involve them. Not they can they can, because they are experiencing the aging, they are taking care of the older people, they are living in the community, they can easily identify the problem or prioritize the research problem as well. And involving them not only during the initial stage of the research, they can also contribute in the method in the research method planning as well. Say, for example, can give suggestions on the types of questions to be asked. And during the data analysis process, they may also share their insight on how to interpret the data, or they may also give advice on how to disseminate the research reports through whatever platform. This is the concept of PPI, patient-public involvement in research. And I suggest employ mixed method approach by collecting quantitative and qualitative data to and complement with each other so that we can have more valid findings. And lastly, to focus on the practical outcomes rather than just focus on its efficacy under controlled conditions. For sampling, I suggest to include a diverse samples of older adults and multiple stakeholders. As I mentioned early in my presentation, the older adults are not a homogeneous population. They have different characteristics. They have various conditions. The health condition change from independence to partially dependence to fully dependence. And at different stages, they require different types of care. Therefore, it is suggested to include a diverse samples of old adults and the caregiver and public people as well. And as I mentioned before, the older adults may live in different conditions, living environment. Therefore, it is also advisable to include older adults who are living in different living environments. For data collection, it is advisable to utilize a combination of instruments, in-depth interviews and observations so as to have different sets of data and they can complement with each other. For ethical consideration, they are old people, but we have to respect their autonomy and ensure that they are informed before they participate in research. And we need to address the unique needs of vulnerable populations and provide appropriate support and protections. Some of the older people may have visual problems, some may have hearing problems, or some may have cognitive issues. And in order to engage them in the research, we have to provide the necessary supports to them and protect them as a human subject. For evidence-based policy, if you remember early in my presentation, I mentioned that current policy mainly focus on aging in place and miss the concept of dying in place. And I would like to close the loop. How can we make our existing policy to be more inclusive so that relevant service can be introduced to support old people to age and die in the home? And for aged care policy, for the development of policy, I suggest the approach to involve the old people, family members, general public at the same time, because they know what is the problem, they can share what they are experiencing. From the viewpoint, we should consider the context, stakeholders, and policymaker. What do we mean by consider the context? Examine our society. What is happening now? What is our major problem? Are we focusing on something which is special? Does that things match with the policy or match with something that we want to develop the policy? If yes, it might be the correct time to propose a policy. The stakeholder have the viewpoint about the policy, and the policymaker have the question as well. If we can provide something or suggestion to the policymakers that can help them to address their problems, then most likely we can be successful. And I suggest to use the evidence to inform policy. We utilize the best available research evidence to inform the policy and to consider implementation science to address the policy questions so that the time between the development of policy and the outcome of of the new policy will be shorter, and we have a shorter time to have the improvement to be happened. And lastly, perseverance. We expect this is a long-term commitment. It is not only the development of policy, it also requires us to engage in the refinement of the policy or revision of the policy as well. From time to time, we need to have ongoing evaluation of the outcome of the policy. And whenever there is upcoming of new evidence, then the policy may have to be revised as well. And form alliance with the stakeholders so as to gather their strength and efforts and continue to ensure the policy match with the needs of our older adults. And the key consideration areas include the healthcare access. How can our older adult access to a rehabilitative service that can support them? And workforce development and support. As I mentioned, we need a stable multidisciplinary team of rehabilitation. The workforce is very important. All along, our healthcare professionals used to provide care in the hospital, in the care setting, in the facilities. And now they are required or they are arranged to support or provide care or deliver care in the place, in the home of the elderly people. They need special skill to do it, and they need support as well. So that with all this kind of development and support, we can maintain a stable team that can provide continuous support to old people. And then housing and environment are very essential because these are the areas that the old people are living in. Technology integration, it can help a lot to make our care to be more efficient, effective. Community support system. When the care is going to be delivered in the community, it is good to seek the support from the community system as well. And lastly, ongoing evaluation and feedback so as to revise our existing policy and make it to be better able to meet the needs of our old adults. These are the references. And lastly, I would like to use this slide and these sentences to summarize my presentation. I propose the PACE-based model of rehabilitation. It emphasizes the delivery of continuous multidisciplinary rehabilitation in the place of the older adults. It optimizes functioning and reduces disability in older adults at all the stages of their later life and supports them to go to age and die in place. And the characteristics of this kind of care are personalized intervention, local support, holistic approach, contextual care, and engagement. This is the end of my presentation, and thank you so much. And your feedback and questions are welcome.
Great, thank you very much, Professor Linda Lee. That was really interesting and very engaging, really interesting, fantastic work. I'd just like to open up to the audience if anyone has any questions or comments or feedback on Professor Linda Lee's model, to please do so. So you can unmute yourself and ask the question directly, or if you're having any issues with your mic, you are free to post in the chat. Yes, please, Simon.
Oh, thank you. Thank you, Professor Linda Lee's presentation. It is very interesting, and I like your terms place-based. That is more very easy to memorize. And aging in place, we have discussed a lot many years ago, and government also I mean Hong Kong government also highlight these terms in a lot of so-called residential care home policy or elderly policy. However, we know it is not very workable, even though it is talking about more than 10 years. Very similar in my PhD thesis, I also discussed something related to the residential care home, and I say even though we cannot aging in place, we can like aging in a familiar district. That means we cannot put the elderly to the residential care home if it is far distant from his or her original living area. So it is also highlighted in some elderly people, older people, and also the caregiver. And today, your presentation enriched much more about aging in place, even more discussed on the dying in place. It is no, this is unlikely discussed in 20 years ago. We seldom talk about dying, but now we are more open, like advanced directive. So we will discuss dying now. So it is good time to combine or enrich the understanding of dying in place through maybe evidence-based research or something like that. And I have one question that is related to your methodology. So you discussed mixed method. Will you apply some funding to achieve this importance, like evidence to achieve it, so that you can implement the later on to advise or inform government to do something related to aging in place and dying in place? Thank you.
Okay, thank you, Simon, for your suggestion and sharing as well. Obviously, I have more than I would like to answer a question and provide feedback to your observation as well. As I mentioned to you, the model is quite new. It still requires a lot of research work to revise it or refine it, and to clarify much of the important concept within the model. And obviously, research will happen. But whether I will apply for funding, obviously it is good to have funding to support the research work. I think you agree that if we conduct research, we need some funding for to support us to conduct research. It is obviously a good idea to get the funding. If you have any suggestion, you are welcome to share the information to me. And regarding the sharing from you, I know that in Hong Kong, the situation is quite difficult because our house tends to be small, and the younger generations tends to live away from their parents, and many older people have to live together, live alone or together with the older partners, and which make dying in place or the healthcare support will be weakened. And I agree to you that we try to, in the past, it may be possible to shift the focus from the home to the community. The concept of community in some area of this world is quite strong. Within the community, the old people get a sense of belongings. Within that community, all the healthcare activities take place. Hospital, home, or clinic, or pharmacy take place with that community, and therefore they stay in that community and they are familiar with that community, and it's also achieved some sort of the concept of aging in place. And in order to develop a community like this, it requires effort as well. Because and what I can say is that currently in some of the country or some of the place, the concept of community is not strong. It is only a geographical location. But in other areas, the concept of community is more than a geographical location. It has all sorts of connection, feeling, and emotion attached to it. And this is also another area that I want to investigate, and it's also another which I wish to achieve in my research life.
Thank you very much. Looking forward to your successful funded research or publication. Thank you.
Okay, thank you for your good blessing.
Yes, Joanne.
Hi, Linda. Thank you so much for your presentation. My name's Jo. I work at Cissy Saunders on the palliative rehabilitation trial. So it's very good for me to hear the word rehabilitation being used alongside dying in place. But even as a rehabilitation specialist and somebody who's very positive about rehabilitation, there is still something jarring, isn't there, culturally, about using rehabilitation in the kind of dying phase, and people find that the two words together uncomfortable. And I wonder whether it's because we have such a passive view of care. And one of the features of rehabilitation is it's a problem-solving approach. Like you said in your presentation, it involves many different people, and they're organising around outcomes relating to function, which towards the dying phase may be just being comfortable in bed, avoiding pressure care, being able to be clean, being able to take fluids, being able to enjoy the company of those around you, a leisure pursuit. But care isn't necessarily thought of as being a problem-orientated activity in the same way that rehab is. And do we have to do a lot more work on raising the profile of care and seeing care as the care workers as being members of the rehabilitation team, and raising the skill of the existing care force? I think as Professor Higginson has recently coined the term the care force, to include the informal as well as the formal carers. And what kind of outcomes in your mixed methods research might this kind of problem-solving care towards the dying phase achieve? What kind of outcomes might we be looking for?
Okay, thank you for your questions. And I do agree that in some place, it's for example in Hong Kong, we see the word rehabilitation seems to be an active approach, and it is related to recovery, regaining the strength, regaining the ability, and recover from disease. And rehabilitation is all along is associated with these terms. And but when we review the literature, and when I recall my experience in CSI for half a year, I was impressed by the practice about rehabilitative palliative care, which is common in the UK. At that time, I started to think about the role of rehabilitation. How can we integrate rehabilitation into palliative care? And then at that time, I start to read the literature, and then ask the people who are providing the palliative care, how do the concept of rehabilitation and palliative care can be integrated. And because of the hospital visits, and because of the suggestion or advice by the experts, all the things, I can get more idea about what is rehabilitation. But we need to introduce, or we need to tell the other people that rehabilitation can cover more activity. Their function is not only for recovery or restorative function. They have a lot of functions. And I believe that if we can do something good and people can see the outcome, then they may know more about it. Regarding the outcome measure, obviously the quality of life is one of the important outcome measure, and the comfort level will be another one, and satisfaction with the care received may be another one as well. And for the caregiver, it might be the relief of the caregiver's burden and caregiver stress might be an outcome for the family caregivers.
Thanks. I'm wondering whether those outcomes would satisfy our funders. I mean, how can we find outcomes that satisfy? You talked about the challenging funding environment. That's just, you don't need to answer that question, but I agree with you. But it's challenging, isn't it, to find outcomes towards end of life that satisfy the funders of healthcare services, the macro level in your presentation.
In that case, perhaps I need to consider outcome of cost effectiveness as well. It may be more attractive to the policymaker if I include the cost effectiveness as one of the outcome, and it might attract the policymakers.
Thank you. Are there any further questions or comments for Professor Linda Lee? No? Great. Well, thank you once again, Linda, for your really insightful and interesting presentation. And thank you to everyone who's attended and listened. I would be grateful if you would be happy to fill in an evaluation form that I've just posted in the chat. If you have attended this session for the first time and would be interested in joining further sessions, then please do join our mailing list. You can just send an email to that email address there. And we do have another seminar coming up on November, and the speaker and the content will be confirmed in the next couple of weeks. Otherwise, thank you and enjoy your evening.
And thank you for being here as well. And I would love to have further discussion with you, and feel free to contact me through my email.
Thank you. Bye, everyone.
Bye.